السلام عليكم ورحمة الله وبركاته. أنا مشعل السعدي. أهلا وسهلا في مبادرة 15 دقيقة طبية المقدمة من فريق طلبة الطب حول المملكة. يسعدنا أن نبدأ أول لقاءاتنا في هذه السلسلة، واللي بإذن الله ستكون مفيدة ومثرية للجميع. أحب أرحب بالدكتور إيهاب اللي راح يقدم لنا اليوم محاضرتنا الأولى بعنوان قراءة تخطيط القلب ECG reading. مدة المحاضرة 15 دقيقة.
Thank you so much. بسم الله الرحمن الرحيم. اللهم اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. Thank you for your initiative. So we start with reading how to read and interpret ECG. So we start with this slide, which shows the conduction system of the heart. And you can see this is the SA node, which is located in the upper part of the right atrium. The sinoatrial node is the normal pacemaker of the heart. It discharges impulses at a rate from 60 per minute to 100 beats per minute. So anything below 60 is called bradycardia or sinus bradycardia, and anything above 100 is called tachycardia. The right atrium also contains the AV node. So this is the AV node. I am doing my arrows around it. And the AV node has an important protective function because it does not allow all the cardiac impulses which comes from the sinoatrial node into the ventricle. It has a braking system to the abnormal discharges. So the normal electrical discharge starts from the sinoatrial node, which is located in the superior part of the right atrium, then the AV node. From then, it goes to the bundle of His, then it goes to the fascicle, and eventually and ultimately it goes to the Purkinje fibers. So this will generate for us the 12-lead ECG, which we are going to see in a while. So this is the way the cardiac impulse is generated from the sinoatrial node to the AV node, and the connection between the sinoatrial node and the AV node is called internodal tracts. So internodal tracts are important. It communicates the SA node to the AV node, and it also communicates the SA node of the right atrium to the left atrium. So this is the way we need to place our electrodes. So we have 10 electrodes and we have 12 lead ECG. So we have 4 limb leads, as I can show you here. There is one in the right upper limb called R, capital. There is one called N, black, in the right lower limb. There is one called L. So this is the right atrium lead. I can put it here, I can put it here, or I can put it here. N stands for the right lower limb. I can put it in the right side, in the right leg, or in the right foot. The L, I put it in the left upper limb. I can put it on the shoulder, on the arm, or on the forearm. The lead or the electrode, which is designated F, that means it is the left foot. So I can put it on the left upper thigh, I can put it on the left leg, or I can put it on the left foot. So this are the limb leads which we are concerned with. Now we have 6 precordial leads designated V1 and until V6. They are designated capital V1 to V6. The only V1 is located near the right nipple, while the other 5 leads are located around and below the left breast. So these are V1 here, then V2, V3, V4, and V5, and V6. It is approximately half an inch from each other. So placing of these leads as required is important when we want to record for ECG. So this is, we go on now. So we go on and we see now a typically normal 12 lead ECG. So this is designated. You can see on the bottom of the slide, we have this 12, the speed of the ECG is 25 millimeters per second. Every 10 millimeters equal 1 millivolt. And on right lower side, we have a date and time. So it is always important when you interpret an ECG to check it is recorded at a speed of 25 millimeters per second. Every 10 millimeters equal 1 millivolt. And there is a box sign at the start of any ECG you will see in your clinical practice. And this is actually denoting the height of the ECG, or every 10 millimeters equal 1 millivolt. Remember also you need to check the date and time of any ECG you check, because it is important not to miss this ECG from another date while the patient is in front of you. It is also important to see if the ECG was done at the time of chest pain or no chest pain. So always check chest pain is positive, is present, or absent when you interpret any ECG. That is very important for us. On the same ECG, I can give you a quick 10 Chamberlain rules of how to read an ECG. So the Chamberlain rules, which we are going to describe, is actually speaking about lead 1 and lead 2. So lead 1 and lead 2 are pointing upwards. As you can see on the arrows I am putting on them. Also, the PR interval should not exceed 200 milliseconds. It should be between 120 to 200 milliseconds. So this is called the PR interval. Again, the QRS complexes should not exceed 110 milliseconds. So it means that the QRS should be narrow. Otherwise, also AVR, anything in AVR is negative. So anything is AVR is negative. So usually AVR is negative. AVR is always negative. And there are only two conditions in which AVR will be positive. One of them is misplaced leads. And the other one is dextrocardia. Dextrocardia has a prevalence of 1 in 15,000. So it is not that common. And if it is misplaced lead, it is usually misplaced with lead 1. So you will see lead 1 is inverted and lead AVR is positive. So this is the way you look to your ECG. Otherwise, you need to note that V1 to V2 and V3 are pointing downwards. So they are pointing downwards. And V4 to V5 are pointing upwards. before we move, we talk about R wave progression. So that is very important for us. What do we mean by R wave progression? You will see so many ECGs in which it is called poor R wave progression. So the poor R wave, we look to the R in V1 and we measure the R in V2, and you can see it start to grow, and it is growing more in V3. And it grows to its maybe maximum in V4 or V5 or V6. So this is called normal R wave progression. Normal R wave progression. And that we mean R wave is growing from V1 to V4 or V1 to V5 or V1 to V6. So these are our rules for R wave progression. It is important to identify the R wave and how it is growing in any normal ECG or abnormal ECG. So let us speak about the waveform. So the waveform are important for us in cardiology. So important to see the baseline. So the baseline is marked before the B wave. This is the B wave, which is due to the contraction of both atria, right atrium and left atrium. If they contract, they produce this small positive deflection, while the whole QRS is due to the ventricle contraction or to the ventricle depolarization. Then we have the T wave, which indicate ventricle relaxation or ventricle repolarization. If there is a U wave, it is positive and it comes after the T wave. So these are the waveform of ECG, and this is the baseline ECG. Important to note the PR interval. So I am going to show you how you can estimate the PR interval on this slide. So this is the PR interval. So the PR interval should be 120 millisecond up to 200 millisecond. The second wave interval is the QT. So the QT stands from here until the end of the T wave. We call that the QT interval. So the QT interval, if it is prolonged, it predisposes to arrhythmia. The most important cause of prolonged QT is ischemia. So the most important cause is ischemia or metabolic, like hypomagnesemia, hypocalcemia, and sometimes it could be congenital, or it could be drug-induced, as in case of antidepressants. So antidepressants or treatment for psychiatry can prolong the QT, and if the QT is becoming prolonged, this can predispose to ventricular arrhythmia. So the whole QT will be prolonged. So it is important to note that. Now we come to the most important part of our talk, which is the ST segment. So the ST segment, where is the ST segment? This is the ST segment, the one I am making it, highlighting it. So this is the ST segment. And in any ECG, I should compare the ST segment to the baseline ECG before the B wave. So in order to see if the ST is elevated or the ST segment is depressed. If the ST segment is elevated, then I am talking about acute STEMI. And if the ST segment is depressed, then I am talking about a non-STEMI. So this is all about the ST segment. Because the only thing that sometimes can help you to differentiate a real ST segment if you are in doubt is actually cath lab. We gave you now the 10 rules of a normal ECG. So we have the normal ECG in front of us. So the first rule is about the PR interval. As we have told you, the PR interval should not be less than 120 to 200 milliseconds. So this is the first rule of the normal ECG. You calculate the PR interval from the beginning of the B wave until the end of the Q waves, until the start of the Q wave. So here I will calculate the PR interval. It should be 120 millisecond minimum, and maximum it should be 200 millisecond. If it is more than 200 millisecond, it is a first degree AV block. If it is prolonged, and if it is shortened, it might be WBW syndrome. So this is the first rule of the 10 rules for a normal ECG. Then we go on to the QRS. As we have told you, the QRS should be narrow. The QRS should not exceed 110 milliseconds or not exceed 3 small squares. If it is more than that, then we are talking about a bundle branch block. We go to the rule number 3, which we also mentioned, that lead 1 and lead 2 should be pointing upwards, or the QRS complex should be dominantly upright. The rule number 4 talk also about the direction of the QRS and T wave in the limb leads, and they should be positive or they should be dominantly upright. The rule number 5 speak about AVR, and we told you that AVR, the B wave is negative, the QRS is negative, and the T wave is negative, and there are only 2 conditions in which the QRS will be positive in AVR. These are misplaced lead with lead 1, or the patient is having dextrocardia, which has a prevalence of 1 in 15,000, and sometimes associated with situs inversus or bronchiectasis or Cartaginer syndrome. We go to the rule number 6, and we already spoke about it. So the rule number 6 talks about the R wave, how it grows progressively from V1 until here it reaches the maximum in V6. So this is one normal pattern. In the second row, the R wave reaches its maximum in V5, which is also normal, and it is minimum in V1. The third row, the R wave reaches its maximum in V4, and this is also normal. So this is the rule number 6 for how you can estimate the R wave progression, which should be normal. This is the R wave progression on the top of your slide, and this is the way you can look to your R wave. Remember, R wave in V1 is small, but it reaches its maximum in V5 or V6. The rule number 7 speak about ST segment. ST segment, as we mentioned, it should be, as you can see on the slide, it is yellow dotted, and it should be always at the baseline apart from V2, and you should compare it to the isoelectrical baseline before the B wave. And if there is an ST elevation, you need to activate the cath lab within less than 90 minutes from the time of the arrival of the patient. And sometimes if you are in doubt, you might still need to go to the cath lab to make a clear demarcation between whether it is a real ST segment elevation or no. Other causes of ST elevation include acute pericarditis, high J point, or LVH. But the most important thing, if you see an ST elevation, think about myocardial infarction as your first and important differential diagnosis. We go to the rule number 8, and the rule number 8 speak about the B wave. The B wave in almost all the leads should be dominantly upright. Apart from V1 and AVR, the B wave should be upright. The rule number 9 speaks about the absence of Q wave on a normal ECG. So in a normal ECG, we should not see Q wave, or we shouldn't see it more than 1 or deeper than 1 millimeter. And the final rule for a normal ECG speak about the T wave. It should be dominantly upright. So these are the Chamberlain rules of how to read a normal ECG. And I stop here. Do you want me to continue?
Thank you so much, Doctor.
I think for the first part, we can complete the second part. You said 15 minutes. I don't know how much we took now.
Yes, 15 minutes. Now we took almost 25. بس إذا كان في أمثلة تبغى تعرضها ممكن نمر
خلاص
عليها
في أمثلة. طيب, let us continue. Okay. So,
yes.
This is the way I am showing you the B wave. So we said B wave is contraction of right atrium and left atrium. And how we can determine if there is an abnormality of the B wave. On the second slide, I'm going to show you.
دكتور.
Yes.
ممكن نمر على الأمثلة على السريع يعني.
أمثلة. I'm coming to this one. Okay, طيب, let us see this ECG. Sorry. I should go back. Okay, this is a patient with mitral stenosis, and I am going to show you how the B wave is actually wide and tall. I look to V1 and I look to lead 2. You can appreciate that the B wave is actually large. This is a young lady with severe mitral stenosis. And I am going to show you now her echo. So I'm going just to clear the mess I caused. And then I go to the next slide. So the next slide, I am going to show you an echo of her. And this is her rheumatic mitral stenosis. I can make it play. So this is rheumatic mitral stenosis, and this is called a hockey stick appearance of mitral stenosis. So this is rheumatic MS, and this is hockey stick appearance of the anterior mitral valve leaflet. And that is why LA is enlarged And also this patient has pulmonary hypertension from long standing. That is why also RA is enlarged. Now I am going to clear the mess I caused, and I am going to show you how is the rheumatic. So this is a typical rheumatic stenosis, mitral stenosis, and you can see this is the color, mosaic color, indicating a severe mitral stenosis causing both atria, left atrium and right atrium, as we can see in our ECG. Sorry, I will show you the ECG before that. So this is her abnormal ECG, how the B wave is quite large and quite tall and quite broad. And I show you her echo showing the mitral stenosis. Now I am going to show you her ECG after mitral valve replacement. And you can easily appreciate that the B wave has come down. So this is the B wave. So the B wave has become, and here in V1, it was inverted in the previous slide. Here it is upright. So the atria, both atria has come down in their size after mitral valve replacement surgery. And this is an example of how we can also see the B wave. So we go on. And we take this example of a 9-year-old child who has come to the ER with some kind of chest pain. And as we can analyze the ECG, we can see that lead 1 and lead 2 are pointing upwards. If we measure the R wave in V1 and V2, we will find that the R wave in V1 and 2 and V3 are small, but the R wave in B4 and B5 are large. So this is a normal pattern. The B wave and the PR interval is normal. The QRS is normal, but we find there is an abnormal T wave inversion in V2, and there is abnormal T wave inversion in V1. But remember, this is a child who is only 9 years old. So expected in children and young teenagers to have T wave inversion, and this is called juvenile T wave inversion, and it does not make or point to any abnormality. Now we take an example of a patient with abnormal PR interval. So we are going to estimate the PR interval here in this abnormal ECG, and we will find out that the B wave is actually attached to the R wave. So the PR here is very, very shortened. It is almost 80 milliseconds or less than that. So very shortened BR interval, as is seen in WBW syndrome. WBW syndrome is important. It is characterized by very shortened PR interval, and there is a delta wave, and this is the delta wave. The delta wave speak about a flared R wave. So these are important also to note. So other than that, QRS is widened. And also again, for the QRS complex, for WBW syndrome, it has a prevalence of 1 in 500 or 1,000 people. 50%. Yes, sir.
دكتور الوقت تقريبا خلص، فممكن تمر على الأشياء على السريع وتنهي.
خلاص, okay. So we are almost done. So WBW syndrome is characterized by a shortened PR interval, widened QRS, has a prevalence of 1 in 500 or 1 in 1,000. There is abnormal bundle of Kent, and the treatment of WBW syndrome is electrophysiology study plus ablation. وآخر دعوانا أن الحمد لله رب العالمين. Thank you so much.
Thank you so much, Dr. Ihab.
Thank you.
We appreciate your effort.